Okay, I'm sure others will join after we get started, but I know how busy people's schedules are, so we will kick it off. First, welcome everyone. I'm Maureen Hensley Quinn, Senior Director of our Coverage Cost and Value team. Excited to be bringing this webinar to all of you. Our goal today is to share some details about our newest model legislation that was released just a couple of weeks ago, I believe. It is currently on our website along with a Q&A. We are going to be talking about limiting out-of-network provider rates to lower costs and increase in-network participation. I am excited to have an esteemed panel join me who had some key insights to developing this model. But I also want to underscore, as with all of NAHSP's models, we developed this with some key state officials who helped first let us know that there was interest, and then second, help us craft a model that is something that they believe they could potentially enact. I know it's very challenging to enact this kind of legislation, but even more importantly, that they could implement. And so we will go through some of the details of the model today, but I also just want to share our esteemed panel. So next slide. Joining today, we have knowledge and insights from health economists, legal experts, and a state health policymaker who is also implementing not this model, but a similar concept. And so you can hear directly from a state official that is seeking to implement these and working with providers to do that as efficiently as possible. I'm joined by Michael Chernew, Professor of Healthcare Policy and Director of Healthcare Markets and Regulation Lab at the Department of Healthcare Policy at Harvard Medical School. Also joined by Robert Murray, who is the current president of the Global Health Payment LLC, but brings a wealth of expertise in state policymaking and implementation from his time serving as the executive director of Maryland's Health Services and Cost Review Commission. We're also joined by Erin Fusey-Brown, who is a professor of law and the director at the Center for Law, Health, and Society at Georgia State University. We're also joined by Margaret Smith Isa, who is Program Development Specialist at the Oregon Public Employees Benefit Board and Oregon's Educators Benefit Board within the Oregon Health Authority. So across this amazing panel, we will hear about the overall concept of what's driving the policy that we helped develop with states and those on this panel. We will hear about the specific details within the model law, and then we will hear from the state perspective on using a reference to Medicare to help cap both in and out of network provider rates. The model itself is focused on out of network, and we will talk through why and what that means. And with that, I am just going to hand it over to our panel. We encourage you to use the Q&A function to input questions throughout this period. We are going to hold all questions until the end so that you can hear everyone's presentations, which may answer some of your questions. And then the other question that we get all the time, yes, we are going to post the slides and we are going to archive this webinar, and it will be posted on NAHSP's site within a week or so. So with that, I believe I'm going to hand it over to Dr. Chernew first, and then we'll go to Bob Murray. But Dr. Chernew.
Maureen, thank you so much, and thank you to the whole NAHSP team for including me. I am really looking forward to listening to, we got to go back one, I think. Oh, maybe we missed one, I don't know. Erin, Margaret, and Bob. But in any case, I guess we can move forward to the next slide. I'm looking forward to the rest of this. So the reason we're engaged in this whole discussion is because healthcare spending is rising and premiums are certainly rising dramatically. The premium for family coverage now in the commercial market's pushing a little bit north of $20,000 a year, which is just an enormous expense that's either paid directly by individuals or by individuals indirectly through foregone wages and by their employers. And it turns out that a lot of that spending growth is due to rising prices. This is data from HCCI, their annual cost and utilization report. And you can see that overall prices have been rising dramatically since 2016, almost 16%, driven by inpatient and outpatient prices. But even professional services have been rising rapidly. And if you look, these are actually pretty smooth price increases in a world where we had low inflation followed by rapid inflation. This notion of price inflation has really been a consistent issue. Next slide. I think you're all moving me to the next slide because I don't have control of them. There we go. So it's certainly not a new problem. And so we're about to talk about some innovative legislation that Aaron, Bob, and Margaret will discuss. But let me try and explain, or at least discuss, some of the things that are sort of not there and why. So as a broadly speaking free market economist, I like to think that competition and pro-competition strategies would work. And in general, I'm basically supportive of many of these pro-competition strategies, although I think to be realistic, they're not going to have that big of an impact for a number of reasons, one of which is markets are consolidated in many places. It's hard to promote competition if you don't have a lot of providers that you can choose between. Even when you do, few patients tend to shop. You see a lot of high-priced providers, even in markets that are structurally competitive, and even when there's transparency data. So the notion that if we were just to provide more transparency data, and by the way, we have a lot of new transparency data everybody's choking on, that will solve this problem is probably just not realistic. I'm very supportive, I think many people are, of antitrust enforcement, but it's generally uncertain, it's often slow, and it's often too late to solve where a lot of the problems are, which is why I think to some extent price regulation can work. And the question is, what type of price regulation do we want? So the next slide. I'm going to talk about two approaches. First, market-wide, where essentially you try and cap prices in the market. Prices can't exceed, 3 times Medicare, double Medicare, some version of that. The advantage of that market-wide approach is you have a wide reach. You basically affect all prices in the market. The challenge with the market-wide approach is the design is complex and enforcement is hard because the payment units vary. Some folks are paid DRGs, some are paid a percent of charges, some are paid bundled payments, some are paid revenue codes. There's a slew of other things that are going on in markets that mean in order to design a market-wide price regulation cap, you really need to think through with a lot of data how you will do that. And you have to reach into the contracts that are being written between the carriers and the providers. If you take a different approach, which is the approach that we're going to talk about today, which is the out-of-network approach, it's a much narrower reach. Out-of-network is a much smaller share of spending, a quite small share of spending in general. But the key, and this really is the key, is there's going to be spillovers that magnify that impact. And so the core question is how big those spillovers are. And that in many ways remains to be seen. I think Bob's going to talk about this quite a lot, so I'm not going to talk about it very much. Maybe in the Q&A we can go there. But one of the nice thing about this is it's much easier to implement because now you're moving away from the contractual relationship that exists between insurers and providers, and you're essentially imposing what happens when there's an out-of-network claim. Which doesn't have to override or get involved with the actual contracting that's going on. And I think the other speakers will talk about that in more detail. Next slide. So I think this will likely be the last slide that I have. But the one thing that I just want to caution people to understand is a penny saved is a penny lost. And what I mean by that is the stronger the price regulation, the bigger the revenue loss for providers. And that's really the issue here that one has to face in the design of this, that while it's very appealing to say, well, we're just going to lower provider prices, understand that the provider will push back about the need for revenue and what will happen when that happens. And so you have to think about that in the design of all the parameters of this model. The two big ones that I think will show up, and I know Margaret will talk about some of these things, is that whether you do state employees versus the whole commercial market matters, because if you do the whole commercial market, you're having a much bigger impact on providers than if you just focus on state employees. And whether you cap prices, caps can't be higher than X, versus whether you set prices. And again, I think Erin's done a lot of work on sort of building out the details of this actual regulation. She'll discuss the choices that were made, but I think those are the issues that one has to think through as one goes through this. And so speaking from my perspective, this is one approach. In some ways, it is on the direct sense, a very light touch approach, and it may in fact have a broader magnified approach depending on how you think markets will evolve. And I look forward to taking questions and hearing the discussion from the audience, from the panelists about those points. But right now, I believe if I have this correct, I'm going to be turning it over to Bob. Let's see if I've got this right. There you go, Bob.
Great, thanks a lot, Michael, and thank you to NAHSP, Maureen and Joanna for having me a part of this panel. In the materials that were sent out, there was a mention made of several examples of large hospital systems that had threatened to cancel contracts and go out of network and to bill much higher prices on an out-of-network basis for the remaining plan members that went to those hospitals. So that the good example of this dynamic and strategy that exists in the private market. But in my experience in negotiating with insurers and self-funded plans, it's a much more pervasive issue that you just don't hear about because even a single hospital could employ this strategy where, during the course of the year, they contact the insurer and say, look, I don't have any rationale for this, but I need a 10% increase. And if you don't do this, I'm going to cancel the contract. And I treat 30% of your members through the emergency room. So you're now going to be paying 450% of Medicare. And so in that circumstance, you have a situation where you could have a provider go out of network, increase plan costs, and then end up having a diminished network. And as we all know, the employers and employees have a desire to have broad networks and of course, want lower plan costs. So as a result of that structure and that dynamic, hospital plans, insurers acquiesce very often. You just don't hear about it. So it contributes to this dynamic of basically having most hospitals in network, but at relatively high in-network negotiated rates. And so it's an overlooked strategy because, as Michael said, there's a very small proportion of services that are out of network. So people say, well, why would that have an impact? But it overlooks this important spillover dynamic, which really is, if you think about it, if you have an out-of-network price cap, that would flip the negotiating leverage back to the insurer, where they could say, here's my negotiated price, this is what I want. And if you don't accept it, provider, then you're out of network and you'll pay the out-of-network cap price. So as a result, you would tend to get in-network negotiated rates that are either at or very close to the out-of-network price cap. And you see this dynamic in a couple of areas. One, the Medicare Advantage program, where in-network negotiated rates are uniformly very close to traditional medical prices because there's a statutory cap on out-of-network payment levels and prohibitions on balanced billing for MA plans for out-of-network services. And also some literature that's been out recently about state experience with surprise bills. So it will not only truncate high out-of-network prices, but also have this important spillover dynamic for in-network negotiated prices. Go to the next slide. So the approach has, as Michael said, the advantage of regulating only the small proportion of services. You can just click through these. It allows for market negotiations without government intervention on the vast majority of services. It would also allow for continuation of alternative payment models for in-network negotiated services, which is an advantage potentially. And then, as Michael said, it's really a low intensity regulatory approach because it's not anywhere close to trying to set up an elaborate regulatory payment system like the one we had in Maryland, or we currently have, that I participated in. With regard to potential impacts, there have been some modeling that have been done both by Rand, Erin Duffy, and her colleagues. They showed fairly substantial potential impacts of the spillover effect. The group that I work with at Johns Hopkins under Jerry Anderson has also done modeling at the state level using Medicare cost reports that kind of corroborate the Rand analysis. And Ellie Prager and Nicholas Tilipman, and you could Google these authors. They have a working paper out where they've done some analysis and created a model using all payer claims databases in New Hampshire and Massachusetts, and they corroborate this conclusion that there could be substantial in-network spillover effects, positive spillover effects. So as a result of both my experience and also this empirical evidence, I've been a very strong advocate of this approach, largely because it is a lower intensity regulatory approach that states could try. Go to the next slide. So just wrapping up, there are, of course, caveats, questions, issues that have come up in my experience and in trying to research this. And I think Michael Chernew in particular raised the issue that the caps on the commercial market may not be 100% the same as the dynamic in the MA market. You've got also network adequacy requirements in the MA market, which demonstrate that dominant providers, you've got dialysis providers that are very dominant in that market, are able to charge rates that are above traditional Medicare. I think the estimate that I've seen is 130% of Medicare. But that still pales in comparison, I think, to the very high in-network rates negotiated by commercial insurers, which are 150 to 240%. So obviously, network adequacy requirements can have an impact, maybe negatively on the spillover effect, but still you're getting rates that are far below what are negotiated in the commercial market. So I kind of think this may be the exception that proves the rule. There's also related to this, I think this is a point that Mike Chernew has raised, that you could have very dominant providers like a UCSF or Stanford or Mass General that employers and employees find highly desirable or must have, and the employers then convince the insurers they've got these providers have to be in networks, and they negotiate high in-network prices to keep them in the provider network. So you could have that as a potential weakness to the strategy. Prager and Tilipman have also noticed that there may be a trade-off between the out-of-network price cap that is in place, the level of that, and provider network, the size of the provider networks. But I don't think that's as much of a problem as long as the cap is at or above marginal costs of providers. In fact, related to this too, I think the folks at Brookings have raised the concern that providers could just refuse to treat patients and undermine the strategy. But again, if the out-of-network cap price is above the provider's marginal costs, then it may not be in their interest to turn patients away. So there's some mitigating circumstances. There are remaining questions that I'm sure we'll deal with moving forward, particularly Erin's presentation. What's the authority that is needed? What level should states look at in terms of setting the price? How do you model this? How do you benchmark price caps? Do you use Medicare? Do you benchmark it to in-network prices? And then how do you ensure that savings will be passed on through this enhanced negotiating leverage that payers have? But overall, I'm a strong advocate of this approach, largely because it is a lower intensity approach and something that states could get their feet wet with and have a very positive impact. So I'll stop there and turn it over to Erin.
Great. Thank you so much, Maureen and NAHSP and Johanna, for all of the sort of legwork putting this together, and to Mike and Bob for that excellent lead in, really explaining the why and what's going on. Why would we spend this time to come up with a model that no state has truly tried before, although we have the closest thing possible with Margaret's presentation following mine. But I think that, you know, it's sort of like, who's going to be the first state to try this? And it's hard to create a model where there is no, where you're kind of creating a whole new legislative model, cutting a whole new cloth. And so I just wanted to kind of explain what was driving that, and that's sort of been presented already. And now we're going to talk about why we put the model together the way we did. All right, so this is just a slide from the Congressional Budget Office that came out in September of this year, where they kind of talk about all of health policy in one slide. And this is about commercial prices in healthcare, and really talking about the three main policy approaches that, you know, are typically bandied about. One is price transparency, the other is promoting competition, and the third is capping the level or growth of provider prices. And again, it's not an either or, it's an all of the above approach, but it's the question of what is the impact? How much of a price reduction will we actually see from any of these efforts? And the conclusion of the CBO was small effects for the first two, at least standing alone. I think price transparency is the basis for a lot of these efforts. So it's not meant to be a standalone policy. But we really, in markets that have little competition left, there really is no avoiding having to confront what can policymakers do. The only thing that's left often is looking at some sort of form of rate regulation. And so this is an effort to wade into and provide a model for a form of rate regulation that may be palatable or doable. Next slide. So this is the NAHSP, or at least the Aaron Fuse Brown version of the NAHSP version of that prior slide. And this is sort of all of the policy tools that, not all, but a menu of policy tools that NAHSP has created and talked about and explored over the years to control healthcare costs, particularly commercial healthcare costs, but not solely commercial healthcare costs and prices. And those range from gathering data. This is, you know, something like the price transparency, but again, it's really building that data as a basis for all the other policy, active state purchasing, mitigating consolidation, overseeing healthcare cost growth. You've been on webinars before, probably, where we've talked about each of these. If there's an asterisk next to an item, it's because NAHSP has put together either a model law or a resource or a toolkit to help states think through what this might look like. So now we're in the fifth category of regulating provider rates. And what is bolded are the out-of-network rate limits that is the subject of today's model. But just want to show that this isn't meant to be a one-size-fits-all. That's not a silver bullet. It's part of a menu of approaches of increasing levels of difficulty, we understand, but also to provide states with the maximum number of tools at their to be drawn on. Okay, so next slide. So this is what's in the model. Maureen provided links. It's posted on the NAHSP website, but it really boils down to this. The model limits in a legislative fashion the out-of-network rates for inpatient and outpatient hospital services to the lesser of either the state's median in-network commercial price for that same service, or X%, a multiplier of the Medicare rate for the same service in the same geographic area. Now, we can talk about in Q&A, sort of how we arrived at this as the model. It might be administratively simpler to just go with the Medicare rate, but we thought that there are some instances, and I think Margaret can talk to this a little bit about how the Medicare rate may not always be a good proxy for a negotiated in-network rate for some types of services. And so having a median in-network rate also is another alternative benchmark that is should be increasingly common to providers and plans, particularly following the No Surprises Act, which uses and relies upon median and network rates to a large degree. The applicability of this model is to all healthcare providers that provide inpatient or outpatient hospital services. At this moment, we did not draft it to include professional services, physicians, other than as they are, billed out as part of the inpatient or outpatient experience. And, that is something that I think that would probably be like the 2.0 version of this. It's complicated enough to tackle the hospital side, but I think inpatient and outpatient, from Mike's first slide, you see that is responsible for a huge percentage of the price growth in the market. And so that will, starting with those two buckets of market prices, I think will have a significant impact, and then perhaps exploring what would need to be added on in a later time. So all of these services include all the applicability of this model applies to both state regulated health plans, so fully insured plans, the state public employee plans, but also ERISA plans. And so we can get into this in the Q&A as to why we think this is that states stand on fairly firm ground, particularly following the Rutledge decision from the Supreme Court a couple of years ago, and to really think through what does this mean, right? Because this is really provider rate regulation. It's not really, although you need the for participation of the plans and the Department of Insurance, this is really not a health insurance regulation, so to speak. It's drafted to be a provider regulation. The administration of this, again, will vary from state to state. So if you have a state health cost commission in your state, then obviously that might be a place to put this authority. Not every state has such a thing. So if you have a health agency that is used to doing a bit of data analysis and would be in a position to regulate healthcare providers in this way and to collect the data and monitor and participate in enforcement, then that would be the health agency in your state. But in addition, there is a role to play for the Department of Insurance. The Commissioner of Insurance has a role to play in sort of monitoring what's going on. How do we know what providers are asking? Well, we get that information from the health plans, and that comes up through the Department of Insurance, as well as the state attorney general, who can step in for enforcement when there's a violation or an alleged violation. There's also some individual enforcement as well that we allow here as well, because a lot of times we won't see this until an individual person is getting a bill that seems out of whack. All right, so next slide. So obviously, a lot of this relies on the state collecting and being able to analyze some data. So from providers, the data that a state might need would be data on negotiated rates, right, to calculate that median in-network rate. Also some claims data, and to be able to calculate growth rates over time, right? Because you want to be able to measure the impact to calculate the savings, right? Because you're going to need to see whether or not there are savings generated and if it's being passed on to consumers in the form of better affordability, or at least affordability that isn't slipping out of control. In terms of those out-of-network hospital payments, of course, that's going to be harder to keep track of. So some of that data is going to need to come in through, if you do have an all-payer claims database, that would be, the place to look, but not necessarily if you don't have an all-payer claims database, then you have to find other ways to get this data. A lot of times the state employee health plan can serve as a proxy. The hospital price transparency rule, the federal hospital price transparency rule can provide some of this data as well, if the providers in your state are in compliance with it, which is a big if, and of course the all-payer claims database. From the health carriers and the plan administrators for self-funded plans, there are some data will be collected there on negotiated rates, again, claims paid to monitor compliance with the out-of-network rate limits. And then also, to some degree, the medical loss ratio and premium growth rates are going to need to be sort of part of the enforcement or part of the overall reporting to see how this is flowing through the premiums to consumers and whether or not we're seeing any savings being passed on or generated. And so for those, of course, you'll need the Department of Insurance's cooperation. Again, the state employee health plan can provide some of this information. And then the transparency and coverage rule, which is the health plan counterpart to the provider federal hospital price transparency rule, could also be a source of data as well. And then if you have a healthcare cost commission, there would be it would be helpful to do sort of an annual report. And so we built this into the model to really report on those trends on in-network and out-network participation. Is this actually causing more health systems and providers to go in-network? What are the rates? What are the impact on premiums? Is this having an effect on access? What is the rate of compliance? And of course, if there is a cost growth benchmark in your state, it would need to be sort of rolled up into that analysis as well. All right, next slide. So finally, on enforcement, the model proposes sort of 3 parts to the enforcement. One would just make a violation an unfair trade practice, which could be enforced by the state attorney general, could authorize the relevant agency, whether it's your health cost commission or health agency, if it receives complaints and is able to investigate, then it can take enforcement action, administrative enforcement action, and any affected individual who receives, a bill or is able to basically demonstrate that the cost limit is not being complied with could also bring an action. The important thing about an unfair trade practice is it also often in many states, it's a statute that's already on the book, right? So you don't have to kind of write a whole new law. You just sort of can take advantage of the existing enforcement mechanism that's already there in your state. It also usually contains either some form of either treble damages, punitive damages, attorney's fees, and costs. And why is that important? Well, it helps the affected individual secure legal representation in order to fight their claim. If they have to represent themselves, then no one will ever be able to enforce a non-compliance against a big, well-resourced health system. And then finally, there are 2 more pieces. One is if there is a demonstrated violation, the provider would have to refund the health plan, the delta, the amount that's above the out-of-network payment limit, and then pay a penalty payment to the affected individual as well, and then provide authority for the enforcing state agency to audit, right? To be able to audit the providers and the payers to be able to support the enforcement and document and secure the sort of information they need to be able to proceed with enforcement. I think that's my last slide. Oh, this was just a tee-up of the Q&A document that NAHSP has. We may not get to all of these questions today in the Q&A, but just so you know, these are the types of questions that are available on the document. So, feel free to look at those as well as the model itself to be able to understand really how we're thinking through, or how states might think through these questions. All right, I'm going to hand it over to Margaret.
Great, thank you so much, Erin. Thanks also to Michael and Bob for the thoughtful comments you've shared so far today. And big thanks to Maureen and Johanna and the NAHSP team for pulling all of us together. I'm really glad to be able to be here and share today. I am Margaret Smith-Issa. I'm with the Oregon Health Authority. And I'm going to talk about our experience implementing price payment caps in the state employee health benefits programs. Next slide, please. So just a quick overview in terms of who we are. Oregon's public sector employee health plans. There are 2 distinct programs that we operate. One being the Public Employees Benefit Board, which provides benefits to employees of state agencies and universities. The other program is the Oregon Educators Benefit Board, which provides benefits to K through 12 school districts, education service districts, and community colleges across the state. Local government jurisdictions, cities and counties, special districts, et cetera, may opt into either program for their employee benefits if they desire. And together, the PEB and OEB programs cover about 300,000 lives. That's including all employees and covered dependents. And that represents roughly 15% of the state's commercially insured population. So specifically looking at how we have approached payment limits under our state employee plans, this provision was established back in 2017 in Senate Bill 1067. And what the legislation did was it created a cap on the amount that health plans or self-insured third-party administrators that contract with the state employee health plans may pay for both inpatient and outpatient hospital services. I think similar to what Aaron mentioned with NAHSP's model legislation, this provision in Oregon specifically applies to the inpatient and outpatient hospital services and does not include professional services. But those limits specified in the legislation set the payment rates at no more than 200% of Medicare rates for in-network hospitals and 185% of Medicare for out-of-network hospitals. It applies to 24 of the state's 62 hospitals. Generally speaking, it's the larger DRG hospitals that are included under this requirement. Smaller and rural facilities are exempt. And also included in the legislation was a provision that the hospitals paid under these limits may not balance bill. And this payment limit took effect in late 2019 for the Oregon Educators Benefit Board and early 2020 for the Public Employees Benefit Board. So we've had this in place for a couple of years now. Next slide. We have done some review of sort of experience and looking at impact in the first 2 years. 2020 being the first full year we had this in place, we saw about 59 million in savings, which was roughly 14% of claims at the facilities subject to the limit. I'll talk a little bit more about some of the things that limited the savings we realized in 2020. But as you can see in 2021, savings further increased. They were estimated to be 112 million in 2021, which is about 33% of facility claims at the facilities subject to the limit. In terms of those reasons I talked about with regard to the fact we saw a lot higher savings in the second year, initial implementation actually resulted in higher payments in some instances, particularly on the inpatient side. So we did some further work and issued administrative rules that subsequently clarified payments were to be made at the lesser of either bill charges, contracted commercial rates, or the payment limit. In that initial year, without having that sort of lesser of requirement in place, there were areas of care where payments actually went up. And then another factor that influenced the sort of higher savings seen in 2021 has to do just with the gradual return we're seeing to more typical utilization levels. In 2020, of course, our utilization was significantly suppressed due to the COVID pandemic, as it was in many communities. And so that led to some difference between what our initial estimated savings had been and what we actually realized. The initial estimates when this was first being implemented were that we would expect to see closer to around 80 million in the first year. So a couple of reasons why that did not occur. Next slide. A little bit more on the impact, and I think some of this sort of stuff is really specific to what the situation in Oregon and what we had going on within our public employee benefit plans. But as we noticed, savings for our programs were largely concentrated in outpatient services. At baseline, they were at a higher percentage of Medicare as compared to the inpatient services. Outpatient prior to the payment limit was running around 250% of Medicare. Inpatient prior to the limit was more in the 175 to 180% of Medicare range. So, so more savings for us on the outpatient side. Of course, those that varied by facility though. So, there would the specific levels of payment prior to the limit, of course, differed by hospital, but on the whole, we're at those levels. And then when we looked at took a recent look at some Oregon Oregon market benchmarking data for commercial payments. Prior to the payment limit, the data sources we looked at showed our payments were running about 5% higher than the benchmark. Our average reimbursement was in the realm of about 215% of Medicare. And then when we look at 2021 now compared to benchmark, our average reimbursement is looking about 20% lower than the Oregon market benchmark. Next slide. And just a few considerations I'll share, and looking forward to some questions and discussion after this. But just to note, I think as Aaron had mentioned, Medicare rates are useful and they're a broadly familiar price benchmark. There's a lot of great reasons to rely on Medicare for that purpose. But as noted, it may not be the most appropriate price benchmark for certain types of services. We absolutely notice this with regard to maternity and newborns. Medicare pricing for those or Medicare rates for those are significantly higher than, from the DRG perspective than what you would see for a lot of commercial plans. Also noted, I think defined payment limits may influence some providers to seek increases beyond current payment levels for certain services. I think that sort of follows some of what I've mentioned. And then also, I think we've noticed, payment limits may influence provider perspectives on advancing value-based payments and transition away from fee-for-service. I think, and this again, I think potentially varies by community. Anecdotally, we have heard the notion that some providers may be less willing to put in the investments necessary to make transitions away from fee-for-service if they're subject to a rate limit. I think there's different ways to consider that, and in particular, sort of depending on where that limit is set. I mean, I think some would note that, certainly a limit at a level of something like 200% of Medicare still leaves significant opportunity to pursue value-based approaches. And then lastly, and this is something that I think Michael had noted in his comments, it is unclear how the payment limits specifically in Oregon, because they're applied to a subset of the commercial market, the exact impact of that on the broader commercial market, I think is still unfolding. So still, I can't tell you, we're not fully clear on how the fact that we've implemented this in the state employee program has potentially, had effect on the broader commercial market. And I think that kind of concludes the prepared comments that I had. So I think, am I passing it back to Maureen now?
Yes, excellent. Thank
Great,
you
thank you.
all to all of the speakers. Really excellent overview. Really appreciate all of the points that are being made. We do have a couple of questions. I'm going to get to those in 1 second. I'm going to start with something that Margaret just spoke of, and it's the percentage of Medicare, because we get this question a lot, and I'm not suggesting that there's a silver bullet answer to this question, but I'm going to pose it to the panel. How do you decide on the multiple of Medicare to use? Again, that's if you're using Medicare instead of the median in-network commercial rate, but how do you narrow down? And Margaret, maybe you could start and just share a little bit about why 200% for in-network and 185% of Medicare out of network. Where did those percentages come from?
Yeah, I can share some thoughts on that. And and to note this, this was implemented through, a bill passed by the legislature. So I think that throughout the process of getting that through, the legislative process, there was a lot of debate and discussion and back and forth and modeling done to look at, various aspects of how this would be set up. I think when you think about what is the appropriate percentage of Medicare, some of that likely needs to rely on some analysis of what rates are currently at, like where things currently stand. I do think there's a very intentional approach to setting a slightly a higher percentage of Medicare for network facilities in terms of 200% for those that that are in network, versus the 185 for out of network. I think, that was a very intentional approach to encourage network participation and incentivize that for hospitals. Yeah, I mean, I certainly invite others to share thoughts as well. I do think, because in Oregon, this was part of a legislative process, there was all sorts of negotiation that went into, sort of the specific aspects of how this was set up. So, back and forth, based on sort of what different parties brought to bear and what analysis showed in terms of where rates were and the level to set. And I think, the other thing to consider is, are there particular savings targets that are desired? You know, that's another aspect of analysis to consider.
Thank you. I'll open it up to others who want to jump into that question.
Well, I just think this is where the rubber hits the road, and it's very important, obviously. I mean, I think preliminarily states could use Medicare cost report data to kind of get a sense of this and see what the general level of commercial pricing is. But to do it in a more refined way, you probably need data, you know, more detailed data, like from an APCD. That's the approach that Prager and Tillotman took. So you could envision that maybe there, you know, you would see price caps varying from state to state in terms of the level, but even within a state, there may be variations. Like I'm in California, we have much higher prices in Northern California than Southern California, so there may be a regional rule with regard to where the price caps are. But I would be in favor of using Medicare. Just on that point, with regard to distortions like for maternity or newborn, there is a data set. The commercial data set that's used for TRICARE, which uses Medicare rates, but it's tailored to a commercial market. So it may be that you could get the benefits of a Medicare-like approach by looking at TRICARE rates for some of these other services that Medicare doesn't price appropriately for commercial payers.
One thing that I think is important for folks to think about is how many bites of the apple they have. So you could start by asking what's the right way, but there's not going to be a right answer. You're basically balancing a desire for lower rates with a desire not to have too strong of an impact on the providers. And that's going to have to be something that's going to have to be developed in sort of consultation. But if you think you can adjust as you move forward, you just have to make a decision about whether you'd like to be relatively loose, relatively weak going in for sort of the proof of concept, and see if you can tighten up over time depending on what happens, or if you want to go in relatively more aggressively and then you know, once you see what happens, loosen up or not as you go from there. But this is really not an analytic question as much as a political question, and it's going to hinge on things like how you think about the revenue at different institutions, how you think about the revenue in the institutions that are serving a large number of public payers, so they're more reliant on the high commercial prices and things like that. It has to be done collaboratively, which is why you're going to have some of the variation that Bob discussed.
Great, thank you. And we're getting other questions related to Oregon, so I want to tackle those right now. Margaret, could you speak to, I already know the answer to this, and I think it's going to be helpful for the audience. What were hospitals' reactions? Did hospitals go out of network? Were they prompted to stay in network? What was the result of setting a limit?
Well, there was certainly a lot of engagement with the hospital community when this was being implemented. You know, I think, as I noted, it applies to a subset of hospitals in the state. So it's 24 of the state's 62 hospitals. So it is really the larger DRG facilities. You know, the way the legislation is written, the requirement is on carriers and insurers that contract with the state employee plan to be in compliance with these payment limits. So a lot of the negotiation with the individual providers was happening between our contracted insurers and the facilities. So we were not necessarily involved in those negotiations in a sort of a primary sense. I do know we did, you know, we had a public rulemaking process. We had a lot of engagement and participation and comment from hospital partners in the process. We did not have situations where a contracted hospital declined the contract. And I think part of the fact that, like, if they decline the contract, they're looking at a lower percentage of Medicare on their reimbursement, supported that. So we did not experience that in our implementation. We also have not had, you know, we really haven't had reports of constraints in access in terms of, hospitals, turning away state employees in any regard. We just haven't heard of anything like that happening. I think to the degree that there have been, in the couple of years since this has been implemented, to the degree that we've heard anything related to maybe access delays, it is more due to things like pandemic delays in care and pent-up demand, now that folks are going in for things that they've been putting off. So nothing that really relates to these payment limits impacting the ability of our members to get the care they need.
And I'll just add, learning about Oregon's experience setting a higher in-network rate to the out-of-network rate is one of the reasons why NAHSP continued to pursue this model. It really it aligns with the theory that is what started our conversations, that setting an out-of-network rate will entice providers to stay in network and to stay at the table and negotiate rates that could potentially be lower than what they were set at before. And so I just wanted to underscore that point, that it is actually being realized in Oregon as they're implementing this. So other questions related to enforcement. And there are a few different ones, but I'll just broach this one. We spoke a lot with states about enforcement as we talked about this model and constructing this model. And so, Erin, I may look to you to speak to this first. But were there any alternatives discussed to using the AG? I know you noted different agencies that states suggested they would use, but there is a question within here. Is there a possibility to use enforcement through licensure of a hospital to help with this rather than going to the AG or using a cost commission, which not all states have?
Yes, so I think it's with all these models, it's sort of hard to draft something that is one size fits all, because we have 50 states and the District of Columbia, and everything is, and every state looks different. And so these were just sort of the ideas of like, every state has a state attorney general's office. Not all state has a healthcare cost commission, but every state has a healthcare agency that is responsible for provider regulation through licensure or other means. And so we tried to kind of pick the best exemplars, but that doesn't preclude states from picking someone else who may be a better champion in that state in terms of has an appetite, has staff. There could be, I could imagine there could be states that have like a really active certificate of need office that is looking for something to do, and that could be a perfectly good place for them to build out their capacity. So it doesn't, yes, so the answer is yes, you could find different enforcement bodies, and it's just a matter of figuring out who is the best one, or one. I think duplicating enforcement authority allows you to avoid the sort of regulatory failure of, if for political reasons there's an AG who doesn't want to go up against the providers, or or it's like a healthcare agency that is overwhelmed and doesn't have the bandwidth to do enforcement, which is why we kind of put it in multiple places so that it is something that a state can pick and choose, but you could also tailor it to your own state.
Just in that regard, I mean, the early rate setting systems in New Jersey and New York use the Department of Health as the regulating entity. So you could conceivably see a state carve out a division within the Department of Health to do this as well.
And I'll just offer a little bit of an editorial side. As we work with states on any model that looks to address high and increasing provider costs, the authority or the agency to take sort of control over this policy is always a question where we start from. The Division of Insurance obviously regulates plans. States have less offices or direct regulation over providers, and it's something that we wrestle with states a lot. And as we continue to pursue different policies, including this one, I do think there's an interest in looking at, should we create a different structure in states that oversees providers directly? And I know there are some, as we've just discussed, but I just wanted to respond to another question that could there be a regulatory structure that gets created? And I think that is absolutely a possibility and something that we've been discussing, but we haven't landed on anything yet. But I just want to respond to that and acknowledge that that's something that others have shared too. Okay, so we're getting some other questions as well. I don't know well, this is a good one. So how cooperative or enthusiastic versus unenthusiastic were Oregon carriers to help with this? So your third-party administrators, how challenging was it to get them on board?
You know, generally speaking, we have good collaboration with our carrier partners. So I wouldn't really identify any specific challenges. I think there are some features in our contracting relationships with the carriers that help support that. For example, simultaneous with passing this legislation that created the rate limit for inpatient and outpatient hospital services, there was also legislation included in the same bill that placed a 3.4% annual growth cap in costs on the Oregon state employee and school employee programs. So operating under that annual cap in our cost growth, we have provisions in our contracts to have carriers help us achieve those targets. And so specifically, we have like financial trend rate performance guarantees, wherein if carriers don't keep costs within that 3.4% cap, there is a penalty payment enacted under the contract to us. So I think that, you know, generally speaking, I would say broadly, we have collaborative partnerships with our carriers, but I think the fact that these other features are in place that are pointing everyone in the direction of managing costs and having consequences for that not being realized helps ensure that we're all rowing in the same direction.
Great, thank you. So there are other questions that I just worry that we're not going to give appropriate time to, looking at how we're running out of time related to how this policy would interact with behavioral health, which is challenging in a lot of different ways. And so I don't want to give it short shrift. So we can go back and perhaps share those questions with our panel and follow up in our Q&A on that. I just want to recognize that we're getting them. I just think it's going to take longer to provide a thoughtful answer. And I will say, as we were discussing this model with states, we didn't get into the specifics of how it would impact behavioral health. And so we can do a little bit more digging on that. But recognizing we're about to run out of time, I just want to do a big thank you to our panelists, a big thank you to your partnership in crafting this model, and then highlight again what Erin said. We really did start a little bit from scratch on this model. While Oregon is an excellent example of how it's working, it wasn't exactly this model that was used. We're taking lessons learned from Oregon, but really appreciate Bob and Mike for sharing their expertise on health economics that really helped craft this. And then Erin, you're just always so wonderful to work with and so amazing in your thoughtfulness. And just a call out to all of the states who helped us really think through implementation issues so that we could craft a model that would respond to some of those. Again, for all of your time today and to the panel, thank you so much. And we look forward to connecting with everyone soon. Thank you, everyone.